Good morning, Mr. Chair. Would you like to bring your bill before the committee?
Yes, I would. I'd like to move to lay House File 3495 over.
Thank you, Mr. Chair. I understand that you also have an author's amendment.
Yes, if I could move the A2 author's amendment, and this is to get the bill into the shape that I would like. There's been a lot of ongoing discussion that has occurred after the base bill was involved, and so this is getting the new language added on, and we will explain it all as we take up the main bill.
Do any committee members have any questions regarding the A2 author's amendment? Seeing none, all those in favor of adopting the amendment say aye. Aye. All opposed say nay. Chair Fisher, to your bill.
Thank you very much, Chair Frederick. And committee, thank you for the opportunity to present the bill today, 3495. This is a bill that's going to be addressing a lot of updating of what needs to happen in the mental health space. At this moment, we have increasing access to mental health care, and it's critical for our state, and we must take steps to help streamline regulations, adapt to meet current workforce environment, address service access barriers, and support mental health to focus on their efforts as much as possible on quality treatment. And we've been doing this process over several years. 2 years ago, we came forward with a start of a uniform standards bill to pull things into shape, to help make things more efficient out there, to make sure people are able to get the care that they need, and help reduce paperwork that's really not needed in the process. And that was very successful, and this is a continuation of what was started several years ago. This is not going to be a complete change of everything, because there's so many other statutes out there and continuing work that happens with the providers out there and with DHS. To that end, paired with efforts to help fix Medicaid reimbursements, I'm bringing this bill before you today centered on policy-focused improvements we can make to our mental health system. This bill is focused on modernizing our mental health services regulation to increase access to services and to allow mental health service staff to focus on quality service delivery. This will lessen the barriers clients face in accessing care and allow providers to focus on care delivery to clients and communities. The bill before you today represents many months of work that mental health stakeholders collectively have worked together across the mental health legislative network and other partners to identify specific areas in statute we can update regulations to advance the goal of increasing access and place the highest value use of staff time. The bill language has been shared with DHS, and we will continue to work with DHS for their technical assistance, as this is very important as we move forward. I know that some of you are in conversations about joining as co-authors, and I thank you for that. And I would ask committee members for their support of this bill, particularly as these are practical policy changes intended to help address the ongoing crisis that we face. This will also become a basis and this is one of the reasons we're laying it over, as a basis for a larger mental health policy bill that will be going forward that may eventually go to the Health Committee. Part of it is we're also laying it over because we want to make sure that there are no costs in here. One of the things that we have requested is a fiscal note to make sure that is the situation. If there are fiscal costs in here, we would break that out separately at a certain point. So these are the steps that we're taking to make sure that we have a good policy bill. If there's any costs related, making sure that we've got that separate to deal with and sent to the appropriate committees. At this point in time, I've got a couple of testifiers with me who will help explain the bill, and I would like to invite them up at this point in time.
Thank you, Chair Fisher. Up to testify first will be Annie Simons from the Mental Health Providers Association of Minnesota. Please make your way to the testifier table, introduce yourself for the record, and proceed with your testimony.
Thank you, Chair Frederick, members of the committee. My name is Annie Simons, and I'm representing the Mental Health Providers Association of Minnesota, or MHPAM. MHPAM is one of the multiple groups that contributed some of the policy proposals for this collaborative legislation. I'm going to briefly walk through the 8 sections of the bill. I'm then going to turn it over to Ms. Anderson, who will walk through the sections of the amendment. We then have 2 mental health service providers here today to testify to further speak to the bill, and we're happy to take any questions and have issue experts available to help speak to the sections if needed. So with that, I will move into a brief walkthrough of the bill contents. Section 1 relates to the use of functional assessments and allows for the option of a provider using validated measurement tools when completing a functional assessment, as well as removes the narrative requirement under a functional assessment. Section 2 creates a narrow exemption to address a barrier to care that was created with a new Uniform Service Standards nursing oversight requirement within children's day treatment. Section 3 of the bill removes Rule 29 requirements for mental health professionals to have specialization in 2 different mental health disciplines. Section 4 of the bill proposes an alternate 2-part requirement to address the on-the-ground challenges that exist with meeting the current intensive residential treatment services requirements for a weekly in-person treatment team meeting with all treatment team members. Section 5 of the bill requires DHS clarity and standardization in provider entity certification criteria. Section 6 of the bill updates Children's Therapeutic Services and Support Statute to reflect uniform service standards regarding timing of diagnostic assessments and allows access to children's therapeutic services and supports through a brief diagnostic assessment. Section 7 of the bill allows for children's therapeutic services and support services to be concurrently provided to a child and caregiver who are receiving 2 separate services at the same time. And Section 8 of the bill changes the licensed alcohol and drug counselor requirement for intensive rehabilitative mental health services to instead align with the assertive community treatment requirement of a co-occurring disorder specialist who has received specific training on co-occurring disorders. And with that, I will turn it back over to the chair for the next testifier.
Thank you, Ms. Simmons. Up next will be Kirsten Anderson, Executive Director from Aspire, Minnesota. Please make your way to the testifier table, state your name for the record, and proceed with your testimony.
Thank you, Chair Frederick and committee members. My name is Kirsten Anderson. I'm with Aspire, Minnesota, and here to walk through the amendment. The following sections provide licensing updates for children's residential care by shifting language from Rule 2960 to statute, focusing on supervision, medication administration, and training requirements. The first 5 sections establish definitions for children's residential care with references from existing definitions in the Children's Mental Health Act and Uniform Service Standards. The next section establishes licensing certification for children's residential mental health treatment. The next section outlines supervision standards for children's residential mental health treatment. The next section describes requirements for administration of psychotropic medications in this setting. The next section outlines training requirements for delivering care to children and services defined by the Rule 2960, with the exception of foster care providers and foster residences. The next two sections update 245I to be consistent with the changes passed in 2023 that eliminate statutory requirements regarding the use of specific assessment tools with children and updates requirements for the functional assessment required update to annual cadence. The next section proposes including an existing code from Armed Services to apply within children's therapeutic services and supports to support aftercare for children when transitioning to the community after intensive residential mental health care. The next section includes transition to the community living services to CTSS services. The next section directs the Commissioner of Human Services to conduct rulemaking that updates Rule 2960 to reflect the training requirements preserved in the rule that outline training requirements for foster providers and foster residences. The final section repeals the sections of 2960 that are updated in this proposal. And I'll turn back over to Chair Fisher for the testifiers.
Chair Fisher.
Thank you. That is the presentation of the bill. And then I do know that we have a couple of testifiers for why we need to have the changes. So if we could have our testifiers come forward, if you'd like to call them Chair Frederick.
First up, we will have Pahua Yang, Vice President of Community Health and Wellness from the Wilder Foundation. Please state your name for the record and proceed with your testimony.
Yep, Pahua Yang. And Mr. Chair, members of the committee, thank you for the opportunity to testify in support of this bill. I especially feel honored to be here because 2024 marks our work in the mental health space for 100 years. So my name, as I said before, is Pahua Yang. I am the Vice President of Community Mental Health and Wellness at the Wilder Foundation in St. Paul. And while I represent Wilder, I want to be very clear that I sit here also representing the many voices of providers and communities across the state. As a community mental health clinic and a certified community behavioral health clinic, Wilder provides a spectrum of mental health and substance use disorder services to our communities. We strive to serve our community holistically through a one-stop shop method of practice. We operate this way because we know that comprehensive and holistic service methods are the most effective at improving health outcomes for both the individual and societal levels. Despite Minnesota's talented, passionate, and intelligent provider network, severe and coinciding crises challenge our mental health and SUD treatment services. The ongoing workforce crisis, chronic underinvestment, and convoluted regulation system that creates and reinforces silos rather than bringing services together under consistent requirements are limiting our ability to serve the needs of Minnesotans. We know people don't come to us as a separate set of symptoms, and we're working to build our programs in order to respond to their needs. This legislation provides many proposals that allow community mental health clinics, such as Wilder, to keep moving forward toward an integrated, holistic model of care. It furthers efforts to streamline regulations that govern a set of services we are working to bring together. And we can only be as integrated as the rules that govern our work allow us to be. By bringing these services together, we will be able to increase access to our community by removing entry barriers, support our staff and programs by flexibly responding to persistent capacity constraints, support clinics' compliance with regulations by bringing some consistency to them, allow our programs to better operate in this post-COVID environment, accessing technology solutions in the same way other fields are doing. And finally, allow our clinicians to work at the top of their licenses and really focus on providing good care to our clients and our communities. I want to acknowledge the good work that this legislature and the Department of Human Services have started in bringing our mental health regulations together in one statute, along with the steps that you've taken to streamline them. Clinics like Wilder and our many colleagues across the state are committed to continuing to work with you, the department, and our community partners to build a better, more effective system for our community, for the way mental health and SUD treatment and care should be delivered now and into the future. We know that this bill is the next step in building a regulatory system with guardrails and the flexibility that allows us to respond to the changing needs of our service community. Thank you for your leadership and support.
All right, thank you for your testimony. Next up will be James Neese, Director of Compliance from Volunteers of America, Minnesota and Wisconsin.
Thank you. You're one of the first to get that right on the first
Please state
try.
your name for the record and proceed with your testimony.
Thanks, sir. Mr. Chair and members of the committee, thank you for the opportunity to testify. My name is James Neese. I am the Director of Compliance with Volunteers of America, Minnesota, Wisconsin. Prior to joining Volunteers of America, I was a senior licensor for the Minnesota Department of Human Services, and I have been a direct service provider in several residential and community-based service programs for children. This legislation provides important updates throughout our mental health service continuum. For children's residential care, we propose to use an existing service code to deliver aftercare for children transitioning to community following intensive treatment. It is of critical importance to support the child and family to sustain the benefit of treatment as they integrate into community life. We also propose revisions to licensing standards because the current standards regulating the Department of Human Services and the Department of Corrections Children's Residential Facilities, which is Administrative Rule 2960, does not effectively meet the needs of the children served and is challenge to comprehend for many licensed providers. Volunteers of America and other providers that oversee residential care for children with diverse and complex needs can attest that operating under the authority of a set of standards that are antiquated and inconsistent does a disservice to the valuable care and treatment we are providing to children and families. Services currently licensed under CRF Rule 2960 are extremely diverse, and providers are too often impeded by this rule as it does not reflect current best practices and services. This proposal provides a starting point to incorporate language from the rule into statute in anticipation of bringing future proposals that will continue this work, as has been reflected in other projects before this committee, to bring all relevant pieces of CRF Rule 2960 into statute. And with your leadership, we can sustain oversight and adjust language as needed for these critical services. Provider experts came together to identify areas of CRF Rule 2960 that are the most cumbersome and unclear. Today's proposal reflects updates in supervision of treatment and services, psychotropic medication administration, and employee training. We believe the revisions advance the goal of articulating quality standards for children's residential care. We look forward to continuing to work with the Department of Human Services on this language and sustaining this important reform effort to achieve clarity as we provide critical services to children in Minnesota who require residential treatment services. Thank you for your leadership and your support.
Thank you for your testimony. At this point, that's all I have for people that have signed up to testify. Is there anyone from the public that would like to come forward and testify to this bill? All right, we will turn it over at this point to member questions. Representative Backer.
Yeah, thank you, Chair. My question there, can you explain the changes to the RN oversight of the medications for children who self-administer the medication? Because there's that change in there. I understand, please correct me wrong, that most of those facilities already have an RN at them.
Chair Fisher.
And I'll call my supporter up here. From what I recall, part of it is, if I remember right, this is the one that deals with the self-administration where the child themselves are already able to self-medicate. And the way the rules are right now, it does not allow them to do that. And these are situations where they'd be able to self-medicate in other situations. So we're just trying to make that process easier. And I'll turn over my testifier to see if there's anything she'd like to add on that.
Ms. Anderson.
Chair Frederick and Representative Backer, yeah, it's true that in our children's day treatment settings, they don't typically have RN oversight for their activities. And so once 245I, Uniform Service Standards, came into being and required that really prevented the services from being able to administer medications. And so those children were disallowed from participating in care. And as you know, when we disallow access to intensive levels of care, that oftentimes prompts need for more intensive care. And so we're trying to make a prudent proposal here that suggests when a child is capable of self-administering their inhaler, their insulin, and their prescriber is able to attest to that and attest to that to the day treatment setting, that should be allowed.
Representative Backer, any follow-up?
Yeah, so if I'm understanding you correctly, before they would get the medication, there would be procedures, and this may be already happening that I'm not aware. There'll be procedures in place to make sure it's the right medicine at the right dose at the right time.
Ms. Anderson.
Chair Frederick, Representative Backer, that is the responsibility of the prescriber, and it's simply being sustained in daily life and in day treatment as in daily life.
Thank you.
Any other questions from the committee? Representative Edelson.
Thank you, Mr. Chair. Thank you for this bill. I actually want to refer to the amendment. If you could go to subdivision, line 7.12. I want to understand a little bit more of a picture of what this is going to look like. So you're in children's residential care for this language, correct? So refusal of routine administration of the psychotropic medication, if the family has decided that they don't want medication of the child and they have come to this agreement, Give me some examples of alternatives.
Ms. Anderson.
Chair
Or-
Frederick, can I invite the testifier to speak to that question? Mr. Neese?
Phone a friend.
Team effort. Mr. Neese.
Yes.
Mr. Chair.
Representative Ellison.
Mr. Neese, so I just want to better understand, because it's really hard for kids to get care right now, right? Especially in children's, we just don't have enough children's residential care. We need more. And so I'm just trying to understand, and I understand, this would be a very troubling, I mean, as somebody that has, as a clinician myself, it's hard if you're not going to take the medication and we've deemed it necessary. So I just am kind of curious what this actually looks like in play. It's language on a paper, but I just, in terms of the staff in that building and the child and the family, tell me what that actually looks like. I'm just curious what the alternatives are.
Mr. Neese.
Yes, thank you, Mr. Chair. In the facility, if you're, I just want to be clear. So this is if the child is refusing the medication or the family refuses the medication, correct?
That's correct. And so if it's
Yeah. So
a
that would-
refusal of routine medication.
Yeah. And that would be primarily up to the decision of the prescriber. If this is something that would inhibit, if this is something that they require as a part of the treatment, then they would have that conversation with the family. If they refuse to take them, to say, on a daily basis or one day, it's really more of just a documentation of the refusal. If it is not going to prohibit their care or the mental health services or improve, have a real negative impact on their treatment, then it would just be a noted, a note in the file, and it would move on.
Representative Ellison, follow up.
Mr. Chair, if you could just follow up outside of this meeting with me, I want to talk with you about this whole section.
Sure.
Thank you.
Representative Hicks.
Thank you so much, Chair. If the testifier would maybe just stay, and I might need Ms. Anderson as well. When we're talking about that particular section, right now, if a child, a teenager, is refusing their medications, are they sometimes being released from a program?
Well, I can't
Denise.
speak in all cases. Generally, no, they'll find some other alternative. Again, unless that decision is up to a prescriber, the prescriber themselves, if they say, I can't treat this child anymore unless the medication is there, then other alternatives would have to be looked at. But in my experience, it's really quite rare, one, that they refuse the medication more than, I guess, as a kind of a power struggle versus really having a strong stance against that. But it would be rare that a child would be actually discharged simply because of not taking a medication.
Thank you so much for that clarification.
Any other follow-up? Okay. Any other questions from the committee? Okay. Seeing no further discussion, Chair Fisher, any closing comments?
I want to say thank you for the questions. This is a bill that we are going to continue to work on. Representative Edelson, I look forward to connecting with you. We are also looking forward to the continued input from the department, and we will be bringing this back in the future as part of the larger package. And with that, I renew my motion that House File 3495 as amended be laid over for further consideration.
House File 3495, as amended, is laid over.